we will discuss the impact of individualization on ovarian stimulation, which of course is linked to what we are discussing before about the euploid embryo transfer. These are my disclosures, and of course, these are my opinions based on clinical experience and scientific data. And I think the first question we have to ask ourselves is why are we connected to this webinar? Why do we go to a meeting like this? And basically it's because we want to do better. We want to provide better care for our patients. And the first thing we all have in mind is pregnancy rate. We discussed this just now. What are the expectations? We want to increase the pregnancy rate of our patients, but not only that. I think we also want to have very low complications, very low hyperstimulation. We want to be very efficient, and we want our patient to have a better patient experience. So it's not only to achieve a pregnancy no matter what. We want to have a healthy baby at home one at a time, but also the whole experience until they reach that point has to be as good as possible. But things do change. I mean, we started IVF in a conventional way of doing IVF. You stimulate your patient, long protocol, day 3 transfer, end of the story. Things change completely in the last 10 or 15 years. And patient needs also change. So this is what makes us change in the way we work. We now have this concept of freeze-hold that sometimes is needed if you have a patient that goes for PGTA or patients at risk of OHSS, or maybe you have high progesterone at the end of the follicular phase. There are different indications that make a completely an unconventional way of stimulating our patients. And we all want to be successful. We want to have a nice and a pregnancy rate in the first cycle. But we know this is not an equilibrated balance. We know the embryo is significantly more relevant than the endometrium. We cannot deny or neglect the endometrial receptivity, but I would say this is 10–20% of the success. This is 80 or 90% of the success. So we have to focus here. And how can we be good? How can we do things correctly? Well, we have to combine these two words. We want to be precise, but if we are precise and not accurate, this is not good enough. We could be accurate, but maybe not precise. So again, it's good, but it's not perfect. If we are not precise and if we are not accurate, maybe we should work in something else. And we want to be here. We want to be precise and accurate. We want to be as good as possible with the dose and the product and the stimulation. So this is what we really want from a cycle. We want to have 3 or 4 blastocysts for a single embryo transfer, if possible. So for that, we need 5 or 6 day 3 embryos. That means 6 or 7 day 2 embryos and maybe 8 to 12 oocytes. And of course, this is going to change according to the age of the patient. So this cannot be universal. This is individualized again. When we talk about pregnancy rates and cumulative pregnancy rates, we may consider the option of freezing. And here I present you data from our group combined with Brussels. This is the 80 centers in Spain, the 15 clinics with the University of Brussels. We combine about 15,000 patients, just 1 cycle per patient. And this is what we saw. The higher the response, the lower the pregnancy rate in the first cycle. This is something that we all know by today. The higher the response, obviously, the higher the rate of freeze-hold in this line. And then when we go to the cumulative live birth rate, it seems that the more the better, if you look at the graph. But if you look carefully at the numbers, look at what happens when you have about 15 oocytes, and this is what happens when you have about double, 30 oocytes. So it's more or less the same, apart from some outliers here. You really don't get that much, but you're going to have a huge increase of freeze-hold because of the risk of OHSS. So actually, we have to have oocytes. Yes, of course. We don't want to be here in the low range, but we have to be careful because we don't get that much benefit if we double the number of oocytes. And we know this also from other studies. This is data from SART, from the ESRM database, huge number of cycles, more than 250,000. And you see that beyond 15 oocytes, live birth rate is stagnated. It doesn't get any better, and the risk of OHSS actually increases exponentially. And this is the same no matter where you look at. If you take data from Denmark, for instance, you see that there's no benefit going beyond 15 oocytes. This was a presentation at EFRE 3 years ago. You see the cumulative. We're not talking here about fresh. We're talking about cumulative live birth rate. You see that it's going to increase with the first number of oocytes. And then once you reach 15, it's going to be again in a plateau. So it may seem that all those extra oocytes that you recruit from atresia are not going to make good embryos at the end of the day. So probably Anything beyond 15 or 18 oocytes is not beneficial for the patient. In fact, there's some data showing that you may get more oocytes, like you see here in this graph, but when you look at the number of blastocysts per cycle or good quality blastocysts, is more or less the same. So at some point, we don't get more blastocysts from more oocytes. Maybe these extra oocytes are not that good. So how can we predict this to individualize the response? We have the quantity markers. Biomarkers is obviously AMH and antral follicle count, and I'm sure you all do this, especially you all do antral follicle count because you all do scans. And those of you who like AMH, I think is as good as AFC or even slightly more precise, but you can do both, but of course you cannot do without AFC. If you want to talk about quality, and there is only one predictor of oocyte quality, and this is women's age. There is no other predictor about the quality of your oocyte. So you can have very low quantity, but if you're young, your outcome is going to be very good. And you can have high AMH, a lot of antral follicles, but if you're very old, they are not going to work, at least the immense majority of them. So we can plan, we can design a cycle, we can design a protocol, and this is what we plan. But then, as you know, life gets in the middle, and sometimes you have a nice predictor, the outcome is poor. Maybe you have a poor predictor, the outcome is better. So we have to use clinical judgment for this. And in fact, this is what happens in biology. Reproducibility is not very precise. And reproducibility, I think, is a very interesting concept when we discuss with patients, because they have to understand that in biology, things do change from cycle to cycle. And just think about menstrual cycle. When we talk to a woman about women's health, we accept as normal to have a period between 21 to 35 days. So we don't expect a period to come every 28 days precise. We may see periods from 25, 28, 31, 30. This is completely normal. If we talk about sperm analysis, if you take 2 or 3 or 4 sperm analysis, the coefficient of variation, as you can see, is 28 to 34. It's a huge coefficient of variation, and this is normal. We consider this normal. Talk about progesterone elevation. This is a hot topic today, and you can measure progesterone, and if you measure twice or 3 times, you may have differences beyond 100%. So again, these differences do exist. And if we come to cycle stimulation, again, if you give the same patient, the same product, the same dose in 3 different cycles, you don't get exactly the same response. And we see this on a daily basis. We see women that maybe one cycle they get 7 oocytes, next one they get 4, next one they get 6. If we change the protocol and it goes in a good direction, then we're very happy because we nailed it. Okay, we did it. If we go in the wrong direction and go from 7 to 4, then the patient is going to blame us because the protocol was wrong. But it's not the protocol, it's the cycle to cycle variation. In this study by Luke Rombots, given exactly the same dose of the same product to the same woman in 176 women, look at the variation cycle to cycle, is up to 25%. It's a huge variation cycle to cycle. So how do we manage this uncertainty? What level of this variability is okay for us? Is this variability going to change my plans, as we were discussing with Professor Bayarelli in the previous lecture? Can we explain some of this uncertainty? I mean, these are things that we have to discuss in advance, so the expectation of the patient is well set. And in fact, we have this concept of coming from the US, and this is the group of Boston IVF with Michael Alper, and they describe this idea of, the more the better. You have one cycle, you get all the oocytes you get, and this is the one and done approach. So you will freeze the embryos, and then you can have as many babies as you want. But we have to be careful with this approach. Look at what happens beyond 15. When you have 15 or beyond oocytes, look at the moderate OHSS, still is happening here. So even in the era of agonist trigger, you still have patients who undergo paracentesis. And I think even repeat paracentesis, this is something from the past. It's been years since we don't see these complications, and mainly is because we are not aiming to have this high number of oocytes. Because OHSS does exist, and this is data from SART, again, from the US. You can see in blue, severe OHSS, but look in orange, moderate OHSS, still big numbers, big complications. And I think we all agree that OHSS is underreported by the clinics. If you look at the OHSS reported by the clinic, and this is data from the UK, these would be the numbers across years. But if you look at OHSS emergency hospital admissions, numbers are significantly higher. So it seems that most of these OHSS cases go unnoticed by the fertility clinics, but then the general hospitals do get these patients. So we have to have this into consideration. This is what we would be aiming. We want to have an optimal response, anything between maybe 8 or 10 to 15. 10 to 15 oocytes is a reasonable number. You will have a nice number of embryos at the end, and you want to go for euploid embryo transfer or single embryo transfer, you will be fine with that. So if we talk about conventional stimulation, we have the EFRE guidelines that were published in October in 2019. And here it's a free document. You can download it for free. You can check how to do all the stimulation protocols in the different patient profiles. But there are a lot of controversy with the things that are not in the guidelines. So guidelines doesn't mean that this is the holy grail. You may have the guidelines, and if you work within the guidelines, you're fine. But you can work out of the guidelines in specific patients if you have a justification for it. Doesn't mean that this is not a law. This is just the current evidence according to the best evidence available. But of course, there are plenty of ideas out of these guidelines that maybe could be done, at least in a research setting. So we cannot treat patients all the same. This is not the era of coffee, the same coffee for everyone. This is the era of Starbucks. You can have coffee in different sizes and different flavors. So with protocols is more or less the same. Patients are different, so protocols have to be different. We have different patient profiles. It's not the same to stimulate a low ovarian reserve patient who is young, or maybe a normal ovarian reserve but advanced maternal age, or a patient at risk of OHSS because he's PCO patient. And also patient goals are different. So we need to use unconventional stimulation. Maybe our patients just want to have one baby in a first cycle and this is it. Maybe other patients come for fertility preservation and they want to freeze as many oocytes as possible. Or maybe it's advanced maternal age with PGTA, or a donor cycle, or a poor responder and PGTA. So according to the needs of the patient, the profile of the patient, we may need to use unconventional protocols for stimulation. And here comes the question, will ovarian stimulation affect oocyte competence? And this is a question that is still running out there. If we take data from a few years ago from Koch in 2006, he showed that the number of oocytes could be related to fertilization, but they clearly saw that this is not the case. They saw that the higher the response, the higher the fraction of immature oocytes. So when you equilibrate this for maturity rate and you take only M2s, the fertilization rate is going to be exactly the same whether you have a low response under 4 or you have more than 20. So the stimulation is not affecting your fertilization. But the thing that is really complicated our life today is that we don't see patients here in the early 20s. We see patients in the late 30s, early 40s, and look at the nuclear rate is rising exponentially beyond 35. And actually, this is where we get most of our patients, beyond 35. So how many eggs do we need? Again, we will have to find an equilibrium between the ovarian response and the chances of finding healthy embryos. Look at women at 43, 44, 90% of these oocytes are aneuploid. So you're going to need a huge amount of oocytes to reach the blastocyst stage, biopsy them, and 9 out of them are not going to work. The main reason for this is age, as I said, and this is the main reason that make us individualize protocols. Not only age, but this is by far the biggest problem inducing infertility today in the Western society. And we know that age is the main complication for aneuploidies. We know that female meiosis is prone to error. If you look at age here beyond 28, this is a very nice review paper from Grun et al. Published in Science last year. And they see a huge amount of trisomies starting at a young age, around 28 or 30. And this is only trisomies. If you take all the considerations, again, this risk is going to be much, much higher. So I think we have to have this in mind, and this is important to show to our patients, because sometimes when they come to see us, maybe they're 40, they're still young women in a society, but they're not so young for having a baby. And because they feel young and they are running this business and they have this car and they have this house, and now they want to have a baby because they feel so young, they have to know the data and have to know that at 40, the chances of having euploid embryos is less than 20%. Are we going to do more damage by stimulation? I don't think so. This is data from Elena from our group, and she showed that the percentage or the number of euploid embryos is going to be similar whether it's a natural cycle or whether it's a stimulated cycle. If you look at beyond a certain number of oocytes, in green you see that most of them are going to be aneuploid, and if you have a conventional response, you will have mainly euploid embryos. So no big relationship. So what product should we use? Should we use recombinant FSH? Should we use HMG or urinary FSH? And I think there are plenty of studies out there. You can read as many as you wish. There you have meta-analysis. Sometimes, depending on who is the sponsor of the study, you may have better results here or better results there. But I think there is a general way of thinking, and we all agree with that recombinant FSH is more potent. And the reason is that the interaction with the receptor is going to be better for the signal transduction. And this is something that we know. When we use urinary products, we have to increase the dose because they are less potent. In these two studies, for instance, you see that by giving REC-FSH, you are going to increase the number of follicles between 10 to 16%. If you give REC-FSH versus urinary products, you're going to have more oocytes, about 18 to 25% more. And if you give REC-FSH, you're going to have more embryos generated, from 17 to 43% more embryos. So I think this is the outcome that we have to focus. We want to maximize the response, not just by increasing the dose by far, but also by giving the best product that you can give to your patients. And we know that if we're looking for euploid embryos, the more oocytes we get, the higher the chances of having euploids. And this is data from Baris Atta when he was in Canada doing his fellowship. He showed clearly that if you have a low response, you have women 40 to 42 years of age, you have around 60% chances of having euploid embryos. But if you have more than 10, the chances of finding healthy embryo to transfer is significantly higher. So again, in these women, you can either stimulate, or if the response is poor, you can do oocyte pooling, as mentioned before, or embryo pooling, so you can increase the chances of finding euploid embryos after PGTA. You can use unconventional stimulation. This work by Filippo Baldi is from the group of the previous speaker, Alberto Vallarelli. They have a lot of experience with this, and they showed that embryos obtained in the luteal phase have similar quality. If you look at the euploid rate, whether they're follicular phase or luteal phase, the number of euploid embryos is similar. And if you combine follicular and luteal phase stimulation, you are going to end up that cycle with more euploid embryos. So the chances of finding a baby will be higher, and the time to pregnancy will be shorter by using this unconventional stimulation. And this is what we get. If you look at the data of euploid embryos in light blue, whether it's a good prognosis patient or a bad prognosis patient or egg donors or even natural cycle, it's going to be more or less the same. Obviously, in bad prognosis, it's going to be slightly higher. But we know today that by stimulating the ovaries, there are plenty of studies that show in the oocytes that you are not going to increase the aneuploidy rate, and you're not going to increase the spindle structure. You're not going to create worse embryos, you're not going to increase the abortions, and you're going to have more abnormalities in the chorionic villi analysis. And this is a question that a lot of patients ask us, that if by pushing the ovary, we're going to have poorer quality of oocytes and poorer outcome. And maybe by nature, doing the selection of the follicle could be better. And now we know that this is not the case. You're going to have same outcome, but more oocytes if you use appropriate stimulation. Finally, when you look at the data, you see that the high gonadotropin dosage is not affecting the euploidy and the pregnancy rates. The previous speaker showed this slide before. This is data from Baras et al. You can see that in different age strata, whether you have young patients or older patients, it doesn't really matter how high or how low is the dose that you use. You have similar euploidy rates. And same also if you look at the euploid embryos, where you have 1 to 5 oocytes, 6 to 10, 11 to 15, or more than 15, you're going to have more or less the same euploid rate in these women. There are other studies similar coming from China, like this one that you have here. Again, higher doses beyond 3,000 international units, cumulative data, of course, is not affecting the euploid rate as mentioned, or according to the number of oocytes obtained. Again, the main problem is age. And here, again, one more data coming from this particular year for 2020, published by the group of Rosenwachs at Cornell. Dr. Irani showed that when you go beyond 35 years of age, your chances of EFRE decrease and the chances of aneuploidy increase dramatically, but there is no effect of the ovarian stimulation on the EFRE rate or the live birth rate after analyzing more than 12,000 embryos being biopsied. So I think we have to be honest also with our patients.
Sono Vaiarelli.
And
Salve signora, allora noi quando ci dobbiamo vedere un attimino questo
we
periodo di
have to
check
be
del
honest with our
digiuno.
patients, and we have to explain to them that the pregnancy potential, where this is the maximum that they may get, and this would be the real pregnancy chances. And we should stay here in the same line, but the problem is that maybe we have an inadequate ovarian stimulation because maybe we didn't choose the right product or the right combination or the right dose, maybe because of comorbidities like obesity that was mentioned before, maybe if we don't have a great lab, or if we have crowded incubators that we have to open several times a day, or if we don't use the best culture media. I mean, all of these things are going to decrease slowly your pregnancy potential, and you are going to end up with your real pregnancy chances with this couple. So to conclude, I think we can say that ovarian stimulation per se does not seem to affect oocyte competence compared to the non-stimulated cycle. Ovarian stimulation beyond reasonable limits may yield higher number of oocytes, but not more pregnancies. Ovarian hyperstimulation syndrome is almost controlled, but not completely, and we have to try to minimize this as much as possible and even to disappear, because we have the tools to not see this syndrome anymore. And I think individualization of the patient needs and patient goals should be the standard of care. Thank you very much.